which are acting on angina pectoris. Now let us see what other things are there with angina pectoris. That is what we know about angina pectoris. And we have seen what are the basic problems with the angina pectoris. This was the figure which we have seen earlier when we have studied angina pectoris. That angina pectoris is actually the disease because of the gap between demand and supply. So there are things which are causing decrease in the oxygen demand. They are causing increase in the oxygen demand. And example of these are heart rate, contractility, preload, afterload. These all will cause increase in the oxygen demand. And when there is a demand is more than the supply, we call it as angina. These are the factors which are responsible for the supply. These are coronary blood flow and regional myocardial blood flow. So we have got agents which can decrease the demand. These are the beta adrenergic agonists, some calcium channel blockers, then organic nitrates like that. And the other one which are increasing the supply, these are the vasodilators like again calcium channel blockers, statins, etc. And we have seen nitrates into it. So these are the various agents which are there, which are used or which are prescribed or which are indicated, we say, in angina pectoris. Now what is angina pectoris we have seen? It is the pain from the heart which is felt in the pectoral region of the upper chest. The pain is radiating through the left neck area. It comes to the left arm and it is a visceral pain, and it is, we call it as a referral pain. Referred pain means actually pain is in the heart, but we feel the pain which is there in the arm and the left hand and the back of the. So these are the reasons it is there. Why it happens? Because whenever there is ischemia, this ischemia will cause the acidosis and loss of the normal ATP sodium potassium pumps, and there will be changes in the membrane integrity. Because of that, the substance like adenosine, lactate, serotonin, bradykinin, histamine and some reactive oxygen species will be released into that area. They will stimulate the chemosensitive receptors, and these will cause the stimulation of the pain receptors, and it will give the sense. From that it will give sense. But since these all nerves are coming together in the brachial plexus, that pain will be sensed that it is there in arm, left arm or left shoulder or back, and thus this we therefore we call it as a referred pain. We have seen all this. Now what are the risk factors which are there? We have seen there are many risk factors like LDL increase, decrease in the HDL, others can see it. Everyone is able to see except Saba. Can you see the screen? Okay, fine. Just a minute. Check now. Fine. So let us go back briefly. So we started with this. We have seen this figure earlier. It was in Goodman and Gilman. We are repeating it. We have seen that it is a demand supply gap. The problems are, that is the reasons which will cause increase in demand. These are heart rate, contractility, preload, afterload. If this increases, that will cause increase in the oxygen demand. These are the situations where there will be oxygen supply will be reduced, and if the demand is equal to supply, then it is a balanced one, no problem. But when the demand increases, then the supply, we call it as a, that will cause ischemia. And these are the agents we have seen, and these ischemia result into pain to what we call as angina. Now, these are the agents which will cause decrease in the oxygen demand. These are the beta blockers, organic nitrate, calcium channel blockers, etc. And these are the agents which will be causing increase in the supply. These are the vasodilators, statins, and antithrombotics. These are various agents which will be increasing supply, and thus these are the treatment, or these are the classes which are used in the angina pectoris. We have seen it earlier. Then we have seen that what happens is there are various chemicals which are released during this angina, and because of this release of chemicals, the impulses are carried, and these impulses are coming in this area that is called as a neck, then shoulder, brachial plexus we call, and from this it comes, and therefore it will show that the pain is in that area. So you can see shoulder, you can see wrist, you can see again shoulder and neck area. So these are the reasons which will have this stimulation of pain receptor, and therefore it will be felt. It is called as a referred pain. Actually there is no problem in this area, but since the neuron coming through this area, therefore the brain will sense that the pain is in this area, and this is one of the major symptoms in that. Now, what are the risk factors which are associated into it? These are the high risk, high levels of LDL, low levels of HDL cholesterol, smoking, high blood pressure, family history, obesity, and particularly men above the age of 45 years, and women after menopause, that is even 45 years, they are prone for angina. So there are many studies are going on. Basically, it started with the 1772 by William Heberden, and these are the problem. And it was earlier thought that it was a breast disorder which was causing severe pain in the females, but later it was found, and not many studies have been conducted on that, and we have got various guidelines. We have seen various types. Let us revise these types again. We have seen them during pharmacology. That first one is a stable, which is also known as a typical angina. It is a classic, or even called as a effort-induced angina, and it refers to the predictable chest pain on exertion. So normally it is not having any problem, but whenever there is exertion, then only the balance between demand supply that changes. During exertion, the heart demand increases, and that much supply cannot be produced. In other cases, the demand and supply are matching, and there is no problem. So this is actually the problem situation where we call it as a stable angina pectoris. It is caused by the fixed narrowing of the coronary artery vesicles, and these are always because of the atheroma or atherosclerosis. The classic angina is the most common form of the angina, and it is also called as typical, therefore. So typical, classical, stable, these are one and the same thing. It is also characterized by a short lasting burning, heavy squeezing feeling in the chest. Sometimes burning sensation mimics like acidity, heavy squeezing feeling in the chest that looks as a muscle pain, and it is characterized by short lasting burning, atypically with extreme fatigue, nausea or diaphoresis, while that is diaphoresis means perspiration, while others may not be associated with any symptoms. They are called as a silent angina. Atypical presentation are more common in women, in diabetic patient and elderly. So in typical, there are sign symptoms of this burning, heavy and squeezing feeling, while in other cases it is not there, and due to fixed obstruction the blood supply cannot be increased, and heart becomes vulnerable for ischemia whenever there is an increase in the demand due to exercise. So accordingly we can plan the treatment. Second one is unstable. Unstable is classified between stable angina and myocardial infarction. Myocardial infarction is an acute attack. Acute attack means all of a sudden there will be blockade of coronary artery, and that will cause total blockage of or total cut off of the supply or reduction of the supply acutely, immediately at that. The unstable angina, the chest pain occurs with increased frequency. It has got more duration of pain and more intensity, and it can be precipitated progressively even with less efforts or even less exercise. Manifestation of unstable angina could be expressed in the following way. Any episode of the rest angina longer than 20 minutes, that is when the rest angina is there or angina during rest is there, which is longer than 20 minutes, or any new onset of angina, or any new increase in the angina, that is means normally which was not occurring and now it is occurring, or sudden development of shortness of breath. These are various symptoms, and the symptoms are not relieved by rest or nitroglycerin. Unstable angina is a form of acute coronary syndrome, which is very commonly called as the ACS, acute coronary syndrome. So in acute coronary syndrome, there are two problems are coming. This is acute angina attack, and another is coming as a myocardial infarction. These are acute. Earlier there were no signs, but now the person is showing signs. So these are called as a acute coronary syndrome. And similar to that is myocardial infarction, which is also an acute, to what we call in common term as a heart attack. So these are there. There are small differences that we shall be seeing, and it requires hospital admission and more aggressive therapy to prevent the progression of to myocardial infarction and death. If this ACS, acute coronary syndrome, is not taken care within time, then it can progress into myocardial infarction, and usually if myocardial infarction cannot be controlled in time or cannot be treated in time, then it results into death. It is characterized by pain that occurs with the less and less exertion, culminating pain at rest. So we have seen the difference between stable and unstable. Stable was having pain only after exercise. Here, even without exertion, it is there. At rest also there. Pathology is similar, which is involved in the myocardial infarction. That is thrombosis form, which may be because of platelet or blood coagulation, and there is a rupture of atherosclerosis, and because of that atherosclerosis rupture. But it is not a complete occlusion of vessel, it is partial one, this is unstable one. Then microvascular angina, it is acute coronary syndrome, is an emergency that commonly results from rupture of atherosclerotic plate and partial or complex thrombosis of the coronary artery. In most cases, there is a disruption of atherosclerotic lesions. It is followed by platelet activation, and then there is a coagulation cascade and vasoconstriction. So this is all overall all this process that result into intraluminal thrombosis. Inside the lumen of artery, thrombosis is there, and therefore there is a occlusion of blood vessel, or there is too much reduction in the blood vessel lumen side. And if this thrombus occludes most of the blood vessels and it is untreated, it will cause ischemia, and after ischemia, because of the ischemia, there is ischemic injury, that is necrosis of the cardiac muscle. In case of myocardial infarction, it is indicated by increase in the serum level of biomarkers like troponin, creatinine kinase, etc. We shall see all this during myocardial infarction also, and changes in the ECG. There are various biomarkers. Biomarker means these are the biological substances which are present in the body, but we cannot determine their normal levels are different, and their levels during certain problem are different. So these are the biomarkers. So these are the chemicals which were present in the body, which are always present, but earlier they were present inside the cell, and therefore their concentration inside the blood was less. But when the heart cells are damaged, these agents now are come. These agents are now available in blood, and because of they are present in the blood, their levels are increasing. So there are many such biomarkers are there. There example of these are lactose dehydrogenase, then creatinine kinase, particularly specifically present that is in the cardiac muscle. It is also present in other muscle, that is called as the CKMB. Okay, then the troponin or troponin T, then SGFT or SGPT. These are various markers which are there, and these markers increases. We shall see all these during angina. Apart from that, it can cause changes in the ECG, and the acute coronary symptom may represent as ST segment elevation myocardial infarction, the non-ST segment elevation myocardial infarction or unstable angina. So there are variety of these. Even myocardial infarction also, it can be called as a STEMI, that is ST elevation myocardial infarction, ST STEMI, and non-STEMI, that non-ST elevation myocardial infarction. So there are both types are present. Either there can be elevation of ST segment of the ECG, or there will not be any change in the ECG. So these are various terms which are called, this is called as a microvascular angina, and last one is called as a Prinzmetal's angina. It is an uncommon pattern of the episodic angina that occurs at rest, and it is due to coronary artery spasm. Symptoms are caused by decreased blood flow to the heart muscles from the spasm of the coronary artery. The individuals with this form of angina may have significant coronary atherosclerosis, and the angina attacks are unrelated to physical activity, heart rate or blood pressure. Prinzmetal angina generally responds promptly to coronary vasodilators like nitroglycerin and calcium channel blockers. And this is, as we have already discussed, it is uncommon, it is not common. It occurs at rest and is caused by coronary artery spasm. Again, it is usually associated with the atherosclerosis. So what gives us clear idea is most of the angina, majority of angina is actually because of atherosclerosis. So usually in angina treatment, we have to go for, apart from the treatment basic or symptomatic or what we can say specific treatment for angina, we have to also go for treatment for atherosclerosis. Now let us see what are various treatments, what are the goals of our therapy. So always we go for a goal. We have seen in hypertension, we want to reduce the what hypertension to certain limit by maybe 10 or 20 millimeter of Hg mercury in systolic or diastolic. Similarly, our goal is to reduce the myocardial oxygen demand, and it is achieved by reduction in the heart's firing rate, that is if we can decrease the heart rate, or to increase the coronary blood flow via vascular smooth muscle relaxation. And the atherosclerotic leg is implicated in that. We have to management, as I told you, we also see that we are also trying to do something about atherosclerosis. Then other way we can do is we can apply lifestyle modification and such non-pharmacological treatments which can be there, which can be helpful. So what are these are, let us see what are various pharmacotherapeutic options. So there are three classes of drugs. They are labeled as, by the guidelines as a first choice or a traditional drug in the angina pectoris. These are beta blocker, then second one are calcium channel blocker, and third one are the nitrates. These are the most common treatment one. So whenever there is a stable ischemic disease, our guidelines will ask you to go for checking, go for diagnostics, and confirm which kind of angina it is, whether it is stable and unstable, whether it is microvascular or it is a Prinzmetal's angina. Then accordingly, on the basis of symptoms, if it is symptom first time appearing, and if somebody is knowing, then usually the best treatment is given is sublingual nitroglycerin is given for immediate relief. We know the mechanism of action of nitroglycerin. It is organic nitrate, and how the nitrates are acting, we have seen them. In the meanwhile, you can revise, you can refresh your pharmacology knowledge. Then second one is beta blocker. They can be there, and if it is inadequate, we can titrate. Here again titration means we shall be observing if these two are sufficient, or after this nitroglycerin was given for immediate relief, but we are going for continuous treatment with this, that is beta blocker. Then if it is not adequate, then we can add calcium channel blocker, or we can add long acting nitrate. And if still inadequate, then we can add third agent, that is known as a ranolazine. Ranolazine we have not studied earlier because this is new. We shall see it as a, we have studied briefly actually, trimetazidine and ranolazine, that these are the agents which are changing the metabolic course of the heart. So these are the beta blocker. First are these. So how you know what they do? They are acting on the beta 1 receptor, which has important, or which is known for important role that is playing in beta 1 mediated sympathomimetic activity, so that increase in the force of contraction, increase in the rate of heart firing. So these are what various reactions are there, and for that it can be we know how we have classified beta blockers. So there are variety of beta blockers we have seen, that is beta 1 specific, non-specific, beta 1 with membrane stabilizing activity, beta 1 agents with nitric oxide releasing capacity, beta 1 agents with having intrinsic sympathomimetic activity, like that. So many classification we have need. Again, pharmacokinetics, those which can cross blood-brain barrier, which will not cross blood-brain barrier. So this was various way by which we have classified it. So these are drugs. We know all these drugs. We have seen propanol, we have seen carvedilol, we have seen atenolol, we have seen metoprolol, and we have compared these, or we have seen their effect. Then nebivolol, esmolol, celiprolol, bisoprolol, so many prolols are there. You can make the list again, as I told you in pharmacology. Here also you can make the list. It started with propranolol, then we have got more specific than propranolol. Propranolol was not specific, acting on both beta 1, beta 2, and if it is there in beta 2, then the problem is it can make big impact on the asthma patient, because beta 2 receptors are present in respiratory tract also, or trachea, bronchi also, and they can increase the bronchial constriction, or they will not allow this beta 2 agonist, which we are studying in respiratory system, to act on them. So we have to avoid these which are having beta 2 activity. We can have more selective beta 1 agents like atenolol, then metoprolol, celiprolol, bisoprolol, and so many, nebivolol, carvedilol, etc. These are various drugs which can have this action. Those which are able to cross blood-brain barrier will able to show depression like effect, fatigue, male sexual dysfunction, enhancement of hypoglycemia, and increased weight gain. These are some of the adverse effects with beta blocker. Calcium channel blocker, we have got two important classes, dihydropyridines and non-dihydropyridine. We have seen that dihydropyridines are actually more effective. They are effective in what sense? Because they are more specifically acting on blood vessels. Because of their binding or because of their activity, they are antagonists, as we say that they are blockers. Because of that, they will block the entry of calcium, and thus calcium will not made available for contraction, and slowly they will cause relaxation. Then next one is this. We have seen one more thing is they are very important, very effective, because they are working quite in both way. Because of the vasodilation, including coronary vasodilation, they are causing coronary vasodilation will cause increase in the blood flow, while other vasodilation will cause decrease in the preload and afterload, and because of that it is working on the both important phases of the cardiovascular or of the cardiac activity. That is both activity, that means will also act on the demand and will also act on the supply. Will increase supply and can reduce the demand. This is how these agents will be acting, and thus they are very important. Then next one, this is and most important are the nitrates. There are many nitrates available. like isosorbate, we call them as organic nitrate. Even there are inorganic also, but organic are comparatively more safe. If you remember, we have seen inorganic nitrate like sodium nitrochloride during hypertension, and we have seen all these agents during our this angina also, and during hypertension also. So these are various nitrates. The mechanism you have seen, they are acting to cyclic GMP, and because of that this nitric oxide will be released or formed, and because of this nitric oxide, which is indigenously present, which has got role to cause vasodilation and decrease of relaxation of the cardiac muscles or other muscles. Because of the relaxation, it will improve the blood flow, and thus they are very important. So these are very important drugs which are there. They have comparatively little side effects. The headache is one of the common side effects which is there, and it can cause postural hypotension. It can cause facial flushing. It can cause the tachycardia, and the adverse events which are there because of the simultaneously administering phosphodiesterase inhibitor like sildenafil, and this combination is contraindicated. The nitrate tolerance, that is desensitization of the blood vessel to vasodilation, is a major problem with the long-term use. That is, or we call it as the development of tolerance or tachyphylaxis. Because of that, this nitrate will slowly lose their efficacy. Cells will get adapted to it, and they will not allow to act it. So this will be the reason. The drug-free interval can be tried, but it produces the risk of rebound angina. Then chronic or long-term use of is implicated to induce oxidative stress of endothelial dysfunction, and the associated combination of long-acting nitrates with calcium channel blocker with patients with increased risk of ADR in the patient with vasospastic angina. So these are various drugs, how we can use it. Example is we have got angina, and simultaneously, or what we call it as this, we call it as a comorbid situation. So along with angina, is there any other disease is present and which can make impact on the angina or subsequent activities? So first one is there is no other disease simultaneously. Then what is our treatment guideline? It will say that go for long acting and long acting nitrate, and then go for beta blockers, and lastly go for calcium channel blocker. Then if it is a recent myocardial infarction, then go for long acting nitrate first, and then go for beta blocker. Then if it is the case of asthma, then in that case of COPD, then try to avoid beta blocker, because we know because of this beta they will be able to act on bronchi, and because of the action on the bronchi, they can cause bronchoconstriction. So use long-term nitric acid, nitrates and calcium channel blockers in this. Hypertension, the nitrates are comparatively, if simultaneously hypertension is also there. Then nitrates can also be there, but comparatively they are less effective, and better one are beta blockers and calcium channel blockers. During diabetes, go for long-acting nitrates, calcium channel blockers, and in chronic renal disease, go for long-acting nitrates. Again, there is a doubtfulness about this beta blocker, and calcium channel blockers can also be used. So these are various drugs. This is what we call as a algorithm, or this is also called as a guideline given, which says that which drug can be used. So what are various drugs apart from that? In addition to that, which we have studied earlier, in addition to that, there are drugs like ranolazine. It is a sodium channel blocker. It is used in treatment of angina pectoris. It inhibits the late phase of sodium channel, that is current, and this sodium current will cause reduction in the myocardial infarction of sodium, and Thus it will reduce the sodium and calcium overload in the myocardiocytes. It will balance the myocardial oxygen demand and supply, and then it will cause improvement in the diastolic features. The drug is indicated for the treatment of chronic angina. Then it may be used as a monotherapy in combination with other transitional therapies. The drug is often used in patients that fail to respond to a first line therapy. Phenolazine is extensively metabolized in the liver, mainly by the cytochrome 3p8 type of enzyme. It is family and it is also by CYP2D6. It is necessary to give the instruction clearly that in polypharmacy involving CT interval prolonging medication, this medication has not to be used. So this is how we have done. Then we have got direct sinus node inhibitor, where we can use this where there is a elevation of the heart rate is there. It is often associated with the heightened risk of the cardiovascular crisis in patients with stable ischemic heart diseases. And this class of drug is believed to inhibit the activities of the pacemaker of the heart, that is sinoatrial node. Therefore, it reduces the heart rate, and the sinus node has some channels that tag as a funny channel, that is F channels, which are the target site for the drug action. The only drug in this class is ivabradine, which acts on this additional or funny channels, which are causing release of this release of sodium into cells, and because of this ivabradine will decrease the sodium load. Then another one is the metabolic modulation. These are because of the inhibition of fatty acid metabolism, which has been exploited for the treatment of ischemic heart diseases. One of the such important treatment is trimetazidine. This drug is recommended in the European guidelines as a second line drug. The drug inhibits the fatty acid metabolism while it stimulates the glucose metabolism, and thus it increases the cellular tolerance to ischemia. And it is reported by various scientists that this trimetazidine if you add it to metoprolol in a randomized trial, it demonstrated 46% reduction in the nitroglycerin consumption. That means that can be so synergistic so that it can reduce the 46% reduction in the nitroglycerin consumption and 47% reduction in the frequency of angina crisis. Particularly, there is a 15% increase in the exercise tolerance. So thus, it was proven to be more benefit when trimetazidine was added along with this trimetazidine plus this metabolic agent which we are seeing. So when it is added to metoprolol, there was such a big effect, such a big change. Then next kind of drug are potassium channel stimulants. Example of this is nicorandil, which is very famous. It has found to be very effective, and it is potent vasodilator. It causes vasodilation by stimulating the potassium channel. It is recommended in the European guidelines as a second choice drug for the treatment of angina pectoris. This has been found to be significantly reducing the risk of the composite primary endpoint of the cardiovascular death, and thus it reduces the fetal non-fetal myocardial infarction, and it is one of the very important. The other agents which are there which can be used, example of these are allopurinol or febuxostat. They decrease the amount of uric acid produced, and this is particularly helpful to decrease the damages, because allopurinol is a xanthine oxidase inhibitor. This xanthine oxidase is causing metabolism of DNase and RNA, that is nucleotide. So thus it will prevent the nucleotide metabolism. Then next one are the other one, like novel therapies are there in addition to that. Example of these are therapeutic angiogenesis. It is the promising approach for the management of refractory angina. It is focused on the regeneration of the dysfunctional or damaged coronary microvascular blood vessels. So far, it has not been very successful. Many patients are refractory to the therapy, and the other ones are there, which can be there. That is using normal treatment of various drugs. It is there. That is whatsoever combination we have seen as a beta blocker, calcium channel blockers, or maybe nitrates. These are given. Then the angiogenesis, when it is done, then because of the neovascularization, therapeutic angiogenesis, that is development of new blood vessels. Angiogenesis means, angio means blood vessel genesis. So therapeutic angiogenesis means development of new blood vessels. It may potentially raise the threshold for ischemia and hence improve the angina. So use of angiogenic genes therapy can also be believed, and in that what can be done is this angiogenic genes are incorporated, or proteins and stem cells are option with the promising outcome, but they have got more difficulties, more complex situations. They are not as easy as we planned, but yes, scientists are planning since many years. They are working on the gene therapy, or they are trying to target with various nuclear agents, and how much they will be effective. Then other one are the lipoprotein apheresis, that is removal of lipoprotein from the blood, and these are removal of this all these lipoproteins which were harmful. They will be reducing the risk of atherosclerosis because they are forming the base of atherosclerosis. So these are very important. Then other thing is the reduction of the concomitant lumetamide microsomal transfer of protein inhibitor, and this lipoprotein apheresis, which is resulting into significant improvement compared to that of the randomized sham therapy, that is which is refractory angina. It is there. So these are various treatments which can be there. Other therapies like coronary sinus reduction, external counter pulsation, or ECT we call it, as that is from externally this impact is given. Then spinal cord stimulation and transmyocardial laser revascularization. These are various treatments which are available. So thus we complete here the angina and treatment of angina pectoris. Then we shall go for myocardial infarction in our next class. Please go through this. If you have any difficulty, please refer your pharmacology first, so that it will be easy and it will be helping.